Well, a couple of years ago, I was working on it's a Students Investing in Geriatric, or Nursing's Future, a geriatrics conference that we were working on. I commented that I really wish that the students can come with me to the nursing home so they could see the amount of critical thinking, the challenges, and also the rewards that are there for those that work in the long-term care setting. And Dr. Mary Koss from the University of Minnesota Hartford Center of Geriatric Excellence was there. And she wisely told me, she said, well, why don't you just videotape yourself doing that? And I thought about it, and I did. So what I did was I chose a topic that's experienced by many of the residents in the long-term care setting, and that's the problem, or the topic of persistent pain. And fortunately, I found a willing interviewee named Alice, who agreed to participate in this project that I was doing. She was just an unreal person, just fun-loving, just really fun to be around. And what she did was, in her mind, she really wanted to help other people with persistent pain by educating nurses and other caregivers about what that whole experience is like. So basically what we talked about was the lived experience of persistent pain. And interestingly enough, a lot more came out of that video than just what it's like to have persistent pain. She reflected a fair amount just on the changes of aging and the transitions that elders face as they age. Many elders face anyway. Some are able to live in their homes for the rest of their lives, but many of them do end up making some changes in their living situation. And so she gave a lot of insight to that whole perspective. I don't know that in the video that I demonstrate caring myself, but I use the video as the basis for one of the discussion boards in my gerontology course. And I do know, just reading the student responses, that it elicits an outpouring of caring and empathy from the students that participate in the discussion. And that caring and empathy are for Alice and others like her. Well, both the physiology and the pathophysiology of the aging are systemic. We have systemic effects from everything, and it's complex. You're constantly needing to determine or decide, is this normal aging or is it disease that's going on? Laboratory values can change very suddenly. They can be more serious. And part of that is the adaptive mechanisms that we're born with often don't either work as well, or they occur so much more slowly in the elderly. Polypharmacy is rampant. It's simply because the incidence of chronic disease increases as we age, and at this time, many of the chronic disease diagnoses are treated with a number of medications. And so every time you're going to increase the number of medications, you're going to increase the risk of drug interactions. You're also going to increase the risk of adverse drug experiences. So, and I've learned anytime anybody has a functional or cognitive decline, that the first place to go is that med list. Is there something new? How is that drug been metabolized? How is that drug eliminated? Nurses in long-term care need to be very cognizant of the role of medications in terms of the effects that they can have on the residents that they care for. In my nursing home practice, we were fortunate enough that we were able to have X-ray, laboratory, EKG services come right to the nursing home. So oftentimes there would be a resident who either didn't want to be hospitalized, or because of end-stage dementia, we really didn't want to send them to the hospital. That change in environment can be very difficult for somebody who's got a cognitive deficit. So that means we would end up treating many times acute illness right in the nursing home. That means IV antibiotics, IV fluids. One time I had a patient that had non-ketotic, hyperglycemic, hyperosmolar coma, and the family just said, do what you can here, okay? They didn't want to have her hospitalized. And so we treated her. We treated her with frequent AccuChecks, IV fluids, IV antibiotics because she had a urinary tract infection, and we used sub-Q insulin for very high AccuChecks. They were in the 600-700 range. She survived. So it's challenging at times, and I have to admit I really enjoy that once in a while.